All right. Thank you all for being here. We're going to give it about 30 seconds to allow more folks to join this session, and then we can go ahead and get started in about 30 seconds or so. All right. Welcome again to the 2026 Digital Health Summit brought to you by the California Telehealth Resource Center. Today's theme is Bridging the Gap, Digital Health for AI, Smarter Care, Stronger Teams, and Sustainable Healthcare. We're glad you can join us for today's session, From Clinic to Community, Scaling Chronic Disease Management Beyond the Visit. I'm Amelia Choa Ruiz, Manager and PI for the CTRC, and I will be your moderator for this session. This session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during the summit. And just a quick reminder, still plenty of amazing sessions later today that you'll need to register for individually. If you haven't already, we'll share a registration link in the chat, and there's still plenty of time to register for one. We hope to see you in our remaining sessions for the day. Before we begin, I'd like to give you a few tips on how to navigate the session. You can use Microsoft Teams functions to ask questions, post comments, and connect with fellow attendees, and also interact during today's session. The session is being recorded and will be posted to our CTRC YouTube channel to view later. And if you encounter any technical issues, please reach out to a member of the CTRC team, either on this platform or contact us at caltrc@ochin.org. We'll hold the last few minutes of today's session for questions and answers and encourage presenters and attendees to keep the conversation going. The work of CTRC would not be possible without funding and support from HRSA and from HCI. I'm so glad to welcome Dr. Gigi Magan, who is a board-certified family physician practicing at a federally qualified health center in Northern California. She serves on the advisory board of the California Telehealth Resource Center and focuses on telehealth implementation and digital health integration for safety net clinical settings. Her day-to-day work includes telehealth and AI-enabled documentation within the realities of a resource-limited practice serving multilingual, underserved communities. Dr. Magan is president-elect of the Sonoma-Mendocino Lake County Medical Association, clinical faculty at UC Riverside School of Medicine, and co-founder of Alma First, a nonprofit focused on health equity and community-rooted leadership in medicine. She writes about clinical AI and responsible implementation on her Substack at drgigimagan.substack.com. And it's my pleasure to welcome Dr. Gigi Magan to today's session.
Thank you so much for having me today. Good morning and welcome. I'm Dr. Jimtriska Gigi Magan. I am a board-certified family physician practicing in Sonoma County. And today we're not talking about digital health as an aspirational luxury. We're walking through the peer-reviewed data, current through this month, on how we scale chronic care for our most vulnerable patients once they leave the exam room and what you can do about it. Next, please. So today, this is a roadmap. We're going to be covering 4 parts: the burden, the evidence, the practice, and also the equity and what is coming. And by the end of this lecture, you'll be able to describe the evidence-based, identify team-based workflows, and apply the 2025 American Heart Association and the 2026 American Diabetes Association guidelines to home monitoring, navigate the 2026 billing updates, and name design strategies to protect equity. And before we continue, I would love to know who is in the room. So I would love if you can drop in the chat your name, the role, and your clinical setting where you practice. And while we're waiting for some of the responses, let's start talking about the burden. So next slide, please. Great. So here's the truth. Medicine is built around the visit, but health really happens everywhere else. Our chronic disease patients see usually under 3 hours a year, and the other 8,760 hours they're entirely on their own. Meanwhile, the math inside of the clinic doesn't really add up, and research shows that to provide perfect guideline-based care, a clinician would need 27-hour workday, and that is impossible. But however, team-based cuts that down, but it doesn't really solve the equation. So the inevitable result is burnout. And as we know, about 40% of our workforce reports feeling burnt out, mostly because they're drowning on administrative tasks and documentation, or what we call pajama time. And the burden. So bringing it a little bit closer to home, and we can all feel the strain here in California. Right now, about 1 in 4 Californians live in a primary care shortage area, with a projected shortage of about 10,500 primary care providers by 2030. That's not too far out. However, our safety net has adapted to survive. And today, approximately 20% of all California community clinic visits happen via telehealth, which is the highest rate in the country. And as we scale this up, we can focus on 5 main conditions. That includes hypertension, diabetes, cardiovascular disease, and COPD, kidney disease, and obesity. And the silver lining is that these are the exact conditions that are most responsive to remote monitoring. And you may ask why. That's because they share 3 vital traits. They're measurable, monitorable, and protocol-driven. And I wanted to pause here for a second because I used to get really confused about what is the difference between telehealth, telemedicine, and telemonitoring. So telehealth is really the big umbrella, and that can cover all remote healthcare services. That includes whether we're treating a patient or a CME course. Also, telemedicine is strictly clinical. This would be your patient visit when you're treating a patient via telephone or video. And telemonitoring is exactly what that sounds like. It's remote tracking of patient data. So now moving to the evidence. The guidelines have already moved to meet the digital model. The 2025 American Heart Association and American College of Cardiologists hypertension guideline came out with the first major update since 2017. And that puts home blood pressure monitoring at the center of the diagnosis and control and adopts the prevent risk equations that take in place of the pooled cohort equations that we used to use before for ASCVD and explicitly cautions against the cuffless and smartwatch devices until they're fully validated. In parallel, the 2026 American Diabetes Association standards recommend continuous glucose monitoring at diabetes onset for anyone on insulin or at risk of hypoglycemia. That's a lot of patients. So home monitoring is no longer an add-on, it's standard of care. Next slide, please. And this is a little bit about the American Heart Association, the Prevent Calculator. And this adds GFR and zip code and no longer uses race. So it adds a little bit of the social determinants of health via the zip code. Now, let's run this like a journal club. So The heavy hitter in the telehealth space now is a 2024 paper by Kelly and colleagues. It was a massive meta-analysis of 75 randomized controlled trials and over 106,000 patients dealing with hypertension and diabetes. They found that telemonitoring drove a systolic blood pressure of about 4.9, about 5% points reduction, and an A1C drop of 0.42% compared to a standard of care. To put that into perspective for the clinicians in the room, this is comparable to adding a second agent. But there's a nuance here. We're sort of mixing apples and oranges because they pulled a lot of different interventions into one, whether that was a basic reminder via text message or a high-tech Bluetooth cuff. And they also measure surrogate markers such as blood pressure and an A1C, but no hard endpoints or outcomes such as a stroke or a heart attack. But even with that noise in the data, the big picture is clear. The strategy consistently drives numbers down across dozens of trials. So the bottom line, let's go back. The bottom line is the virtual care is not a lesser substitute, but it matches usual care on the numbers to track. Okay, the next slide. Okay. So the next one, so what does good implementation actually look like? We have Dennis and Koifman published a study earlier this year in the American Journal of Managed Care that illustrates this perfectly. They looked at Medicare patients using remote monitoring. But the crucial piece is that they paired the technology with a dedicated nurse care coach. And the results were striking. At the start, about 100% of patients met the criteria for stage 2 hypertension, and a year later, only 25% did. Their average blood pressure dropped from 152/85 down to 132/74, which is great. But there were some caveats here. This was a single clinic, there was no control group, and one of the authors actually works for the vendor that made the monitors. And because of that, we need to take this with a grain of salt. The numbers may be a little bit inflated by highly motivated patients or staff. But nevertheless, the main point here is that the technology brings the signal, but it's the human coach that drives the outcome. And next slide, please. Great. So now focusing a little bit on hypertension. As we know, the target is as close to 120/80 as is possible and safe. And now we can use the prevent calculator. And for stage 1, lifestyle changes first. We can add medication if the blood pressure is uncontrolled at 3 or 6 months, or if our patient has cardiovascular disease, cardiovascular disease, diabetes, CKD, or a prevent risk score of 7.5 or higher. So make sure that you have a link to that calculator. Now, stage 2, we will start 2 agents at once, no longer just a single agent, because that has better control, and then a single pill combination for better compliance. And the highest yield combination is nurse-led with a prescriptive authority. This was highlighted by a meta-analysis by Bay Demu published last year. And they found a 16.5 drop in systolic blood pressure compared to usual physician-led care. I do want to point out too that there was a lot of variability in how these trials were run. So it wouldn't focus so much in the number itself, because implementation in each clinic may be a little bit different. I do want to be mindful about the digital divide, and this is something that I really care about and I want to talk about, because patients facing economic hardships struggle the most consistently to send their data to the team. And we can't let technology leave the most vulnerable patients behind. On the flip side, though, remote monitoring is a great diagnostic tool. And about 1 in 5 patients have white coat hypertension. When they come in clinic, the blood pressure is a little bit higher, but once they go home, the blood pressure is normal. So this helps us to only treat those patients that truly need treatment. Now, moving on to diabetes. CGMs, or continuous glucose monitors, are a game changer because it takes diabetes from a single quarterly A1C, so every 3 months or so, to a real-time daily picture. And in 2025, the review in JMIR Diabetes confirmed that using CGMs in primary care significantly improves a patient's in-time range. But there is a caveat. We can't just give out the devices, right? We need to have trained staff that interprets all the data and also educates the patients. And the clinical benefits are universal across all income levels, but unfortunately, access is not. Our uninsured patients may look at approximately $160 to $500 a month to cover this device. And insurance can definitely decrease this, but there's prior authorizations and this may delay care. And if cost is a true barrier, there may be a workaround. How about placing a clinic-owned CGM, kind of like a Holter monitor when someone has, we're testing for arrhythmia. What if we can have a patient wear a CGM in the back of their arm and it's blinded? So meaning that they live their life, they eat what they eat without cheating or adjusting their diet. And then that also gives us a perfect 2-week diagnostic timeline, or what is their true baseline without forcing the patient to actually having to buy one of these, but at least it will help us with management. So let's pause here for a second. I wanted to go back and then see if there are any questions at the moment, and then just look at the chat for a sec.
I don't see any questions that have been posed just yet.
Great, let's keep going then. Okay. So then, how about in heart failure and COPD? Those are two of our most common chronic diseases. And when it comes to remote care, heart failure gives us the most robust data. A 2026 systematic review showed a reduction in overall mortality. I do want to point out that specific mortality data wasn't a preprint study, so we need to take it with a grain of salt. But the data showing a massive drop in hospitalizations and improved quality of life is fully peer-reviewed and rock solid. And that's on the bottom of the slide. And the actionable pearl here is surprisingly low tech. We need to build a hard, predefined trigger directly into our clinical templates and workflows. For instance, let's say a patient now gained 3 pounds over 24 hours or 5 pounds in a week. The patient should know exactly where to call or who to call, which would be the nurse line. That way we can catch the overload on like volume before there's a crisis or they need to be hospitalized. And this we have also seen in COPD, a 2025 randomized trial evaluating a 12-week home monitoring program was able to cut readmissions by half, dropping from an average of 3 readmissions down to 1.5. And the interesting thing is that they didn't use any fancy technology or gadgets. They use just tracking sheets, phone calls, and breathing exercises. So ultimately, digital health doesn't have to be super high tech. It just means structured human follow-up delivered remotely. Next slide. So the next one, let's look at our last paper. And this is the hottest topic right now, which is the ambient AI scribes. An early study last year in JAMA Network Open by Olson et al. Looked at 260 clinicians across 6 systems, and the results were very promising. using an AI scribe dropped the self-reported burnout from 52% down to 39% in just 30 days. But as you know, there were limitations. There was no control group. They tracked it for 1 month only. And these were likely very highly motivated early adopters. And it didn't measure patient outcomes. And the other piece that I want to highlight is that there are also safety guardrails that we need to consider. There was a separate study last year also by Ng et al. That looked at 29 different studies and showed that while AI is great with perfect clean dictation with an error rate of less than 9%, which is great, that error rate can spike to over 50% if there is a patient with an accent or multiple people talking in the room. Think about the visit where you have multiple family members, some people are talking, and it would be hard for the AI scribe to really catch everything, or if you have an interpreter in the room. So the lesson here is that if you're going to be using this tool, pilot it carefully. Make sure that there's a human in the loop, reviewing the notes, and audit the accuracy against the language that your patients actually speak. Next slide. So let's put it all together. If we look at telehealth for hypertension, for diabetes, and remote monitoring for heart failure, the evidence is solid. It's great. When we look at nurse-led medication adjustments, scaling RPMs across systems, the CGMs and COPD, the trend is very positive. But the studies are still of moderate quality. And ambient AI is highly promising, but there's still more research to come. And we do need to stay grounded here. A massive 2024 review in The Lancet looked at digital health interventions and found that about 42% of them showed zero significant clinical benefit for patients. Even worse, there's also a massive blind spot in the research. Almost none of these tools were tested in safety net clinics. So, our golden rule here is let the actual proven clinical outcomes dictate how much time and money we invest in new technology in our safety net. So next slide. So the practice. Let's talk about finances because that's also a very important piece when we talk about different interventions. So a single 30-day hospital readmission can cut an average of $15,000. On the flip side, running a comprehensive remote monitoring program is about $1,200 to $1,500 per patient for an entire year. But do keep in mind that just leaving hypertension uncontrolled adds another $2,500 a year in extra medical costs. So the bottom line here is if the program prevents just one readmission per patient per year, it pays for itself 10 times over. And this is something that you can share with your CFO. Now let's talk about the practice. So this is your 2026 cheat sheet, and this is for educational purposes. This is not billing advice, but the highlighted rows are the brand new updates. So first, let's look at the Advanced Primary Care Management, or APCM. These are the codes G0556 through 58, and they pay a flat monthly rate based on the patient's complexity. So multiple chronic conditions, which means no more minute counting. And second, we finally have CPT 99445. This covers 2 to 15 days of remote monitoring data, completely ending that frustrating old 16-day minimum. So CCM, or chronic care management, basically pays you for the time you spend managing a sick patient's chronic conditions. And APCM, which is Advanced Primary Care Management, pays you a flat rate for being the patient's primary care hub, regardless of how many minutes you spend or how sick they are. Now, if we look at this sort of a like traffic lights. So red light, you cannot do APCM and CCM. So you cannot do both in the same month. Green light would be APCM and remote monitoring. And yellow light would be CCM and remote monitoring. You could maybe stack these, but you have to be very, very cautious because you have to maintain strict separate time logs so that you're not double dipping. And finally, on the policy side, we have some good news. Medical covers RPM for established adults, and those crucial telehealth federal rules have been extended through the end of 2027. Next slide. Another exciting model is the new Access model, which is a volunteer 10-year CMS initiative that officially launches next week. And it really fundamentally changes the math. So instead of the old fee-for-service model, this model pays you based on outcomes. You get your full payment for actually hitting a measurable target, like a specific drop in blood pressure, rather than just billing for another office visit. This massive operational win is here's CMS waiving the in-person visit requirements. That means your remote monitoring tools aren't just an add-on anymore. They can become the primary way you manage patients. It really focuses on cardio, kidney, metabolic diseases, plus MSK and behavioral health, which that covers a big range of our population. And the applications opened earlier this year, and there are enrolling applications. Next slide. Now the practice. So it really boils down to your workflow. If you kind of throw all the data to your clinicians, they're gonna be bogged down with alert fatigue. So no. So instead, what we could do is a clinician center model, a dedicated care team that can filter the data, handling the heavy lifting of the setup, the billing, the initial outreach, and then the clinicians come in when all the information is clean, actionable, and there's a summary. And a 2026 paper showed that this exact model hits a massive 93% provider satisfaction rate. And at the end of the day, the role clarity, not technology, is what really helps with sustainability. So the practice. So how do we build this without breaking the clinic? It really comes down to 4 simple phases. First, use your EHR to identify your top 10 to 20% highest risk patients. 2, consider using cellular devices instead of the Wi-Fi hurdle, because there's a lot of patients that don't have access to the internet, and we'll talk a little bit about that later. Keep loaners on hand and onboard patients in the language they actually speak. And then third, let your nurses run the show. One nurse can handle approximately 300 patients, managing the alerts so the doctors can deal and other clinicians can deal with the escalations. And finally, bill for the work. Capitalize on the fact that the 16-day rule is no longer there, and you can bill for those 2 to 15 days that aligns with the new access model. And start small. Target a small cohort of patients, prove that you can monitor and decrease their blood pressure at 90 days, and then use that to scale to the next phase. Next slide. So practice implications. The clinician, if you're a clinician in the room, here are 5 things that you can do next week with 0 new technology. First, standardize a written home blood pressure protocol that actually review that when the patient comes in. 2, empower your nurses to practice at their top of the license using standard titration orders. Third, when a chronic patient cancels the appointment, try to book them for a same-day telehealth visit. That can be really helpful. 4, take 5 minutes to review the ambulatory glucose profile with your CGM patients. And 5th, have weight gain triggers into every single heart failure care plan. And if you're a clinic leader, now your job is to build the infrastructure. Here are 4 things that you can do. Formally approve your nurse-led standing orders. Consider building a loaner device library. So patients can borrow blood pressure cuffs or CGMs, invest in cellular-enabled devices, and train your community health workers to act as digital navigators. Next slide. So focusing now on the policy here in California. If you're thanks to AB 744, we have commercial payment parity. And even better, AB 32 made Medi-Cal telehealth flexibilities permanent. That includes audio visits, so telephone visits. And we know that this is a lifeline for patients in rural communities, older patients, non-English speaking patients. And now, due to the rural health transformation, we have 233 million federal funding flowing to rural communities now. And on the federal side, we bought ourselves some time. The 2026 Appropriations Act officially extended the Medicare telehealth flexibilities through the end of 2027. But I want to be clear that this is not a permanent fix. So we need to continue advocating for the flexibilities. There is the Connect for Health Act currently in Congress, which is a bipartisan bill that allows to keep these flexibilities permanent. So focusing now on equity. And without careful design, these technologies can help reach the patients who have the easiest access while leaving those that need us the most or the most vulnerable behind. And this is a massive blind spot. According to the Pew Research Center latest broadband fact sheet that was published late last year, only 54% of adults in households earning less than $30,000 a year have broadband access. And we rarely measure equity in our programs. And safety net data shows that non-English speaking patients usually avoid tech for fear of inconveniencing our staff. So what can we do? As we talked about, we can provide free devices, we can onboard in native languages, we can use community health workers as navigators, offer audio-only options, and track demographic data. And definitely make sure that you audit your AI for bias before deployment. So let's put it all together. So we have Maria. She is 58 years old, has hypertension with a blood pressure of 158 over 96, an A1C of 9.2, two jobs, limited English. She missed an appointment. And unfortunately, then things worsen and she ends up in the hospital with a preventable event. So that was the old model. Now the new model, we get the EHR flags her, a bilingual navigator hands her a cell phone, a blood pressure cuff, and a glucometer. A nurse coach can review the readings and catches a spike of 172 over 104 within 2 hours. Then a clinician can titrate her medication via telehealth, and then it could be a completely different outcome. Same patient, different systems. So the horizon, what is coming? What are the 5 trends to watch? So number 1, we talked a little bit about the ambient AI scribes. There's more research to come. 2, there are closed loop CGMs or automated insulin delivery system like an artificial pancreas that are expanding beyond just type 1 diabetes. Predictive AI in your EHR is starting to flag patients that may that may crash within 90 days. There's also hospital at home that is officially CMS backed to replace specific inpatient stays. And no matter what you adopt, definitely we need to keep in mind to validate for bias and validate across the actual population that you serve. So what can you do, next slide, by role? To the clinicians in the room, you can run a quick EHR report to find your 50 highest risk hypertension and diabetes patients, standardize your home BP protocols, and commit to trialing an ambient AI scribe for just 1 week. And let's see how it goes. And then for the nurses, advocate for dedicated care coach roles and standing titration orders, and formally request a documentation burden assessment. And to the executives in the room, you can pool your actual 30-day readmission data and costs, model the return on investment for a remote monitoring program under the new access model, and then approve a tight, maybe 20 patient pilot program. And finally, no matter what your role is, try not to reinvent the wheel. And our CTRC actually has lots of great, amazing resources. They have the free 2026 guide, sustainability calculator, and no cost technical assistance. So definitely reach out. And in closing, I want to leave you with this final thought. The clinic visit is just the beginning of care. It's not the boundary. The clinic is where care is planned, but is the community where health is actually made. Chronic disease is continuous, and the clinical guidelines are universally agreeing that home monitoring is central to managing it. The evidence is real across hypertension, diabetes, COPD, heart failure, and we know that underserved patients can also benefit. We know the model works well when it's a team-based and provider-centered, and as of 2026, there's finally the payment structure that can pay for it. And remember, equity is a design choice. So let's start narrow this week. Pick one condition, one population, one channel, one team, and one 90-day metric. Thank you. So I'd like to open up the floor now for any questions.
Thanks so much, Dr. Magan. See lots of virtual clapping in today's session. Some really great information shared. We do have a couple of questions for you. We have in the chat Daniela asking, as far as billing, why is RPM not reimbursable yet?
So let me go back to that slide. So that is a good question. My understanding is that the CPT 99445 covers 2 to 15 days of remote monitoring data. So in theory, that would cover part of the remote monitoring. Is that something that you've seen in your practice, or someone on the chat that can comment on that?
Hi, this is Daniela. I'm from Indian Health Center of Santa Clara Valley. Our understanding from our billing department is that as an FQHC, we cannot bill for RPM only services. So we do have an RPM program, but we're pairing it up with a CCM. So that way we can sustain the program because it's quite expensive to work with our vendor. So yeah, as far as we know, we cannot bill only for RPM visits.
Yeah, I think that is a good question. My understanding from what I was reading and preparing for this visit is that you could have the remote monitoring and CCM, but again, you have to have very diligent logs so that you're not double dipping. But that would be an option. But definitely talk with your billing department as well.
Thank you for that. Another question that we have is, how do you design these types of care models to work around patients with limited digital access or even limited digital health literacy?
Great question. So from what I've seen, and I also practice at an FQHC, so a lot of our patients do use technology. For instance, they use WhatsApp for social media or Instagram or different things, but they don't use it for their health. So here is where community health workers can work as digital navigators. And that's how we can bridge that gap. And so when patients may not have, for instance, a smartphone, or they may not have, apps, we can definitely use the loaner cell phones, some of, the flip phones that may not need access to the internet, but we can still do telehealth via a telephone. So that would be a way to kind of bridge that gap. And another thing that would be really helpful is maybe consider doing a digital literacy assessment of your patient population, and then be able to identify who are those patients that may need a little bit more help, that they would benefit from a digital navigator that can help them, for instance, understand, do they have an email address? Can they use it? Like, how do you log into the health portal if there's one at your institution, and so on and so forth. So that's how we can bridge that gap.
Thank you so much for that. Another question in the chat from Noor is if a patient is enrolled in the access model on the HT track, would they then be excluded from reimbursements for RPM for the same condition?
Oh, great question. To be honest, I am not sure. My understanding is that the access model is gonna take off next week. And then it's focusing on cardiac and metabolic diseases. So in theory, that should cover heart failure and MSK. But to be sincerely honest, I am not entirely sure yet how that would pan out. But if there's someone in the audience that has more information, please feel free to unmute.
It looks like someone has reached out to answer a couple of questions, but we can also follow up and send out additional information with our thank you email.
Thank you.
And another question is, what's a top lesson or top lessons learned from implementation that others should adopt and others should avoid?
Yeah, so like I mentioned, try not to reinvent the wheel. I think starting small, because every clinic, right, is going to have slightly different patient population. And so we need to really tailor that intervention to your patient population. So starting small, maybe with just 10 patients, seeing, for instance, you can pick hypertension and then see if perhaps having a nurse coach with a loaner phone, if at 90 days, if we're being able to really reduce blood pressure by at least 5 points, that's a great win. And if we can maintain up to 90 days, then maybe you can scale up. Now, no longer is 10 patients, now maybe it's 20, 30, 50, right? So that would be a way to kind of get started. And then caveats or things to try not to do is to go too big too quick, right? Because it is really with a small pilot that we can really tailor the workflows. Do we have the alarm system, or do we have that protocol that we can have for the nurses to utilize when they get one of those alerts that maybe the blood pressure now has gotten to 180/90, right? Like, what do we do then? So kind of taking the time to basically troubleshoot.
Yeah, great advice. Thank you so much again, Dr. Magan, for answering questions in the chat and providing some really helpful and relevant information for us today. Some really great tips on focusing on one condition, one population, just extremely actionable. So thank you for that. With that, I'm going to hand it over to Jocelyn, who's going to close out our session for today.
Thank you so much, everyone. Thank you, Dr. Gigi Magan. It was such a pleasure having you here today. Another virtual round of applause. I appreciate all the information and resources. So I'm going to help with wrapping up our session today. Thank you, everyone, for the questions in the chat. We're here to support one another, so I love to see people engage. For ongoing support, check out our website at caltrc.org, where you can find events, webinars, and on-demand resources, and more. You can reach us via email at caltrcocean.org at any point. If you have any questions, need technical assistance, or just to access our resources, I put our email in the chat. Now I want to introduce you to our upcoming events. Part of the resources that we offer, CTRC is proud to host the 2026 AI Cohort Series and Office Hours. This series builds on the foundation and success of our 2025 AI Bootcamp, expanding opportunities for deeper learning and practical application. This is a no-cost virtual cohort, which is amazing, supporting healthcare organizations and advancing AI use in real-world care delivery. As part of today's summit, Summit attendees have the opportunity to complete the first 3 sessions of the cohort series, with 3 additional sessions being offered in July and August, along with dedicated office hours to provide ongoing support, discussion, and shared learning. So please feel free to scan the QR code, or we can encourage you to visit the page so you can get additional information. I went ahead and put it in the chat, so please visit our page, scan the QR code so you can get more information. And we do value your input. So before we wrap up, I'd like to invite everyone to complete our short exit survey. Your feedback directly informs the types of programming tools and resources we develop moving forward. So you should see that pop up shortly. Oops. Thumbs up if you all are seeing it. Awesome. Please fill out our survey so you can let us know how we did today. We review every answer to make sure that what we provided today was critical and up to date for you. And then it helps us to understand the resources we can share in the future. So please feel free to take the time to take the survey. I won't close out this session so we can hear some of your responses. We'd love to hear from you. To continue on, I'll share how you can stay connected with CTRC. We have a variety of QR codes here, but the one thing that I'll share today is sign up to our newsletter. All our up-to-date information is shared via our newsletter. You'll get our up-to-date resources, new toolkits, new blogs we're posting, upcoming events. That's the main way that you can stay up to date on all things CTRC. And thank you so much, everyone, for joining us today. I'll leave the session a little bit open for a while, just so we can get some of your responses to this survey. But that is it. Thank you so much for joining us. Thanks, everyone. We'll shortly close out. Excited to see you in our other sessions.